All right. So welcome to the first meeting, guys. So a little bit about what we are trying to do with these journal clubs. So we kind of just wanted to um, allow everybody the opportunity to share their knowledge and teach their peers, and that's a great way for us to learn and for the presenter to learn as well. We also try to invite physicians to every meeting. So today we have Dr. Alvarez joining us. He's a sports medicine fellow. I'll tell you a little bit about him, a little more about him in a minute. So we do things like this to kind of get everybody thinking and learning in a different kind of way. And it's definitely a great way to create more of a community and a different way to learn. So today, Alex will be presenting. Here's our agenda. So Alex is going to do her presentation, and then we'll take care of some CRG monthly general things. Okay, so about Dr. Alvarez, did you want to introduce yourself, doctor, or did you want me to do that for you?
You can go ahead. It's fine.
All right,
Thank
so
you.
I actually met Dr. Alvarez at Carroll T Hospital when I was in my family medicine rotation. So we rotated together a little bit, and I heard he was doing his fellowship in sports medicine, so I thought that would be perfect for today's presentation. So he completed his MD in Cuba. I'm not going to try to pronounce that name. I'm just gonna destroy it. But at that university, he completed his residency, like I said, at Carroll T in Miami and finished that in 2023. And then he just started his sports medicine fellowship at Meharry Medical College in Nashville, Tennessee. All right, Alex, take it away.
All right. So thank you everyone for joining. Thank you, Dr. Alvarez, for being here. So the topic I wanted to discuss with CRG today is sex and gender differences in sports injuries, specifically with a spotlight on ACL injuries. So I first got involved. Sorry, you can stay on the same slide for a sec. I first got involved in a project looking at sex and gender differences in sports injuries through AMWA, which is the American Medical Women's Association. So they actually have this big overarching project looking at sex and gender differences across lots of different medical conditions. So hypertension, diabetes, of course, different incidences of cancers. But this project part that wanted to get involved in was sports injuries. I have a particular interest in sports medicine and orthopedic surgery. I have a background in a little bit of athletic training. So this was the topic that spoke to me. And I got to learn a lot through this kind of literature review project about different sports injuries and specifically ACL injuries. So like I said, AMWA is doing this for a lot of different topics in sex and gender differences. So if you're interested in learning more about it, you can go to AMWA, you can talk to me. We're still working on this project, and ultimately the goal of this project is to create educational fact sheets that can be distributed to different universities and medical school curriculums. So this is still an ongoing project, but I'm excited to share sort of what I've learned, at least a little bit about ACL injuries with you guys today. Next slide, please. So looking at sports injuries in particular in the literature, after the 1970s is when you see a lot more information about in sports injuries in female athletes. And that's because there's, at least in the US, legislation was passed that enabled like Title IX and things like that, that enabled more women to participate in sports at higher levels, like collegiate levels, high school levels, things like that. So with an increase in female sports participation, we saw an increase in female sports injuries, and then also an increase in discussion of female athletes and female injuries in the literature. So some things that have popped up, again, specifically looking at some sex differences and gender differences in sports injuries. So before we kind of dive into that, just to create a little bit of engagement, can anyone tell me what is the difference between sex and gender?
I was waiting for Andrea to chime in, but I will answer your question. So sex is basically what you were assigned at birth based on your external genitalia or chromosome, could be either. And gender is what you feel most comfortable identifying with. That could be male, female, non-binary, fluid. There's a bunch of different definitions. Actually, Andrea just published an article about this. I don't know if I'm allowed to be saying that out loud,
No,
but
you can say that. I'll post
okay.
it in the chat.
Okay. Yeah, and that's honestly like what I just read, so that was like at the tip of my head, but it's a really great article to read. Sorry,
Perfect.
back to you.
No, that's perfect. Thank you. So yes, so sex differences, we're thinking about more of the genetic, chromosomal, things that you can't really change, hormonal things can be more related to our sex and our chromosomes, versus gender, which is more of a societal construct and has more, like, can have different implications, even in different societies. And so when we're looking at sports injuries, when we think about gender specific, you can also kind of think about it as sports specific, because, like, again, taking US sports, for example, if you take a US female hockey player and a US male hockey player, they're still playing the same sport, but they have different rules, different, and those different rules can also dictate like the injury incidence within that population. Same thing with something like lacrosse. Lacrosse is supposed to be non-contact for female athletes, but if you've ever watched a lacrosse game, you know that there definitely is a lot of contact, whereas men's lacrosse is allowed to be full contact. So again, you may see different injury incidences just because of the differences in the sports that are played by men versus women, and also the rules that are instituted within those sports. And then when you look at sex-specific differences in sports injuries, we're looking more at, again, like biomechanical differences, physiological differences. Again, like hormones show up a lot in the literature, which we'll get into a little bit more. So again, in the literature, there are a few injuries that repeatedly come up where they are looking at and identifying sex and or gender-based differences in these sports injuries. Concussion is a huge one. It's been much more popular in the literature, in the public sphere of knowledge, with CTE, subsequent to concussion. And so this is a huge topic that's getting a little bit more funding. ACL injuries, which we'll be talking a little bit more about today. Achilles tendon rupture was something that our group's literature review saw some differences as well. Bone stress injuries, which was also mentioned in the article that I sent out in advance of this meeting, and also overuse injuries. So different kinds of overuse injuries, we see different incidences in males versus females. And then, we'll get into this a little bit later, but there's a lot of gaps in the literature and opportunities for further research. So for example, one population that is not very well represented in the literature at this point is transgender athletes. There's been a number of transgender athletes in the popular media and social media and the news, but in terms of actual literature studying these athletes and incidents of injury in these athletes, our group didn't find any literature published on that yet. We found one article that started looking at transgender athletes and the effect of the hormones that they may be taking on things like their hemoglobin levels, but it didn't specifically look at their injury incidences or changes in their injury incidences compared to other groups. So there's a lot of opportunities for further research in that realm, as well as, again, I keep mentioning this part about the effect of hormones on possibly influencing the incidence of different injuries. There is some discussion of this in the literature, which again, I'll dive into a little bit more. But one thing to note is that a lot of the literature on things like the effect of the menstrual cycle on whether a female athlete is more prone to getting an ACL injury or not is all based on like self-reported, they're telling you like what they remember being their last menstrual period, and then you kind of make an estimate mapping out like, are they in the follicular cycle or not. And so just having it based on, subjective reporting is maybe not as accurate versus something where you're like monitoring someone's blood levels of hormones, again, like at different stages of their injury cycle. So again, is that like feasible to do? Who knows? But there's still opportunities, again, in the literature for more concrete data on the effect of hormones on sports injuries. So after that brief introduction, next slide, we've got specifically looking at ACL injuries. So for ACL injuries, the literature so far shows that there is an up to 8 times risk of injury of having an ACL tear or rupture in a female athlete versus a male athlete. And this is across sports, across, players in the same sport. So soccer players, whether they're male or female soccer players tend to have a much greater risk of an ACL injury, even though they're playing the same sport and largely have the same rules. Just a little bit of an introduction to the ACL. So as you can see on the image on the right, this is kind of our standard anatomy image. The ACL, the anterior cruciate ligament, is composed of 2 bundles that arise from that lateral femoral condyle, and it runs anteriorly and medially and inserts on the tibial plateau. Importantly, it really doesn't have a blood supply, and that's a big part of why it does not heal on its own and why the only treatment for an ACL injury is surgery, surgical reconstruction. The function of the ACL, as we probably all know, is to prevent the anterior gliding of the femur relative to the tibia, and it also provides some rotational stability, so prevents excessive internal rotation of the tibia. The ACL is often injured during sports where they're making a lot of sudden pivots or cutting movements because you have a rapid deceleration. So you have this, your femur is still moving relative to your tibia. And you can also have it when you're doing a lot of cutting and rotation. A lot of the injuries happen with this like valgus force and internal rotation. So you're really stretching the ACL past its limits, and then it ends up rupturing. The symptoms that you get with an ACL tear are pain, popping, swelling. You may have all of these, you may have only some of these. You don't have to have all of them to have an ACL injury. But what you often see is rotational instability. So someone could still be able to walk in a straight line just fine. But then anytime they try to pivot or turn, that they feel like their knee may give out. And again, you'll see this sort of anterior gliding, excessive anterior motion of the femur relative to the tibia. To diagnose an ACL injury, the physical exam findings that you could do are the anterior drawer test and the Lachman test. These are very similar, where you're trying to move the tibia anteriorly relative to the femur. They just have different angles, 90 degrees versus 30 degrees of knee flexion. And then the MRI, of course, is the gold standard for diagnosing our ACL injuries. Next slide, please. So what we found in our literature review is a number of different risk factors specifically that can be attributed to females or males in terms of their risk for ACL injury. You'll notice in the female column, there's a lot more risk factors that they have found so far, which would fit with the fact that female athletes are about, again, 8 times more likely to suffer an ACL injury than male athletes. So in the female column, just being female there seems to be some sort of risk factor, in the literature for that. Having an increased BMI seems to increase the risk of ACL rupture. And then there are a number of different biomechanical differences between female versus male athletes that seem to be related to ACL rupture. So something called the decreased strength ratio, an increase in the knee valgus. So their knee is generally a little bit more angulated inwards, that's valgus stress. An increased slope of the tibia. So again, the tibial plateau generally has a little bit of a posterior slope, but in females often is more steep. The female athletes often have a smaller overall cross-sectional area of the ACL, as well as a smaller femoral notch and tibial spine. So the insertion sites are smaller, making them a little bit more weaker. Decreased number of fibrils, again, related to the smaller size of the ACL, and an increased Q angle. So what is a Q angle? If you click, an image is going to pop up. Oh, not there. If you just click the slide, sorry. Perfect. So the Q angle is this measurement where you create a line from the ASIS, the anterior superior iliac spine, to the middle of the patella, and then you make another perpendicular, not perpendicular, you make another line from the middle of the patella to the tibial tuberosity. And the angle in between those two lines is the Q angle. The Q stands for quad angle because it's measuring the kind of force on your quadriceps tendon, on your patellar tendon, based on, you know, where these insertion points are. So it's the vector of the tension on the quadriceps muscles. If you click on the slide again, so this is kind of a schematic illustrating the differences largely related to the different structures of the pelvis in a female versus a male. So the female pelvis generally has a wider pelvic outlet. You have this, you know, very different shape compared to a male pelvis, and that ends up making a wider Q angle than in most males. So generally in a female, you'll see a Q angle around 18 degrees versus in a male, you'll see around 13 degrees. And that difference, I mean, 5 degrees may not sound like a lot, but that is a lot. There's also, of course, variation among female athletes in their Q angle and then among male athletes. So these are all kind of mean numbers. But this angle seems to have, again, a bigger effect on whether someone is at risk for an ACL injury or not. And as you can see with this wider Q angle, it does force that knee into a little bit more of that valgus stress again, which we already said was a risk for ACL injury is valgus stress on the ACL. So a greater Q angle is increasing that stress. If you click on the slide one more time, you go back to our risk factors. So again, looking at the male risk factors, more biomechanical risk factors again, you know, if you're a male athlete, you seem to be at greater risk of an ACL injury if you have, you know, what I thought was interesting and need to like read more, a decreased standing Q angle, but also if they have a lot of posterior knee stiffness or this navicular drop. And then in both female and male athletes, no matter who you are, it seems you have an increased risk of ACL injury if you just generally have more lax ligaments, so generalized laxity, as well as if you've ever ruptured your ACL before, you're at an increased risk for re-rupture of your ACL. So just looking at these risk factors, obviously a lot of them you can't change. I mean, increased BMI is really the only risk factor in this group that we found that's something that you can have a big impact on. One other thing that they've noticed in the literature is that helping train that another piece related to ACL injury is how people land from jumps. So a female athlete versus a male athlete, again, with the different biomechanics of listed here may have different landing patterns, and that can also contribute to their risk of ACL injury. So in addition to, you know, optimizing BMI, the only other thing that they really do in terms of prevention of decreasing risk is working on training different landing patterns. And that's about it. So a lot of these risk factors, there's not much we can do to decrease a female athlete's risk of ACL rupture, just looking at these risk factors, unfortunately. Now, clicking on the next slide, one other part of the literature that I thought was particularly interesting is that the topic of hormones comes up a lot. So for one, different papers have shown that the ACL specifically does have receptors for this different, you know, sex-specific hormones, so testosterone and estrogen and relaxin, which we see, you know, you'll hear about in like your OB-GYN rotations, for example, because it helps relax ligaments to increase the size of the pelvis in order to deliver a baby. So estrogen and relaxin and testosterone receptors have already been found on the ACL. Now, how important are these receptors? We don't entirely know yet. A lot of the research on that has been done, you know, in laboratory studies and isolated studies. So, you know, exactly how important or how, you know, many or impactful these receptors are is not quite known. There's also been some research on the effect of the menstrual cycle on different ligamentous injuries, including ACLs. And so again, like I mentioned, a lot of it is like subjective and self-reported data on where someone is in the menstrual cycle. It's not necessarily like measuring, exactly what their progesterone levels are versus their estrogen levels. But so far, the research seems to suggest that there's an increased risk of muscle and tendon injury during the late follicular period of the menstrual cycle. There was also a study done looking at the rate of injury in people who took oral contraceptive pills versus non-OCP users. This one study found that there was a 20% decrease in injury in those who took these contraceptive pills. So again, like I mentioned, a lot of these are retrospective studies and they're focused on self-reporting. So there is a need for prospective studying and biochemical testing to confirm that suppressing ovulation decreases the risk of ACL injury. There's also, this one study is focused specifically on OCPs, combined oral contraceptives. So comparing, is there any differential impact of there's so many different contraceptive methods, that have more of a systemic effect versus a localized effect. So, again, if we want to say that OCPs help, we should probably do more research on all the different kinds of contraceptions to see if any of them help. Now, considering also that the ACL has receptors for these different sex-specific hormones like testosterone and estrogen, one question that hasn't been really elucidated in the literature yet is what the effect of someone who just naturally has elevated androgen levels, or someone who has PCOS, polycystic ovarian syndrome, who will have increased androgen levels, or someone who uses exogenous testosterone, for example. What is their risk of ACL injury or rupture compared to others who don't have excess androgen within their system? Does a female athlete who has PCOS have a lower rate of ACL injury than a female athlete who doesn't have PCOS? There's no literature on this yet. So this is an opportunity for research as well. And then finally, like I mentioned before, what are the implications for muscle and tendon injuries in the transgender athlete? Because again, so far, the only research that I've seen on this is that testosterone suppression was having a decrease on their muscle size. It was decreasing their hemoglobin levels, but again, it didn't specifically look at their rate of injury. On the next slide, like I mentioned, in terms of prevention and treatment, there's not a lot of risk factors that we can modulate based on that previous slide. So again, we have these like warm up sort of projects or warm up and training exercises that are being promoted to help try to decrease ACL injuries across sports. And so this one is specifically called FIFA 11 Plus. It's shown up in the literature review a number of times. Of course, FIFA is soccer focused, but all of these exercises, these warm-up exercises, any athlete can do. And they have implemented it and studied it more in our male soccer athletes, but are also trying to promote it among female soccer athletes and female athletes to prevent ACL injuries then. And as I mentioned, working on landing mechanics as a way to specifically address decreasing ACL rupture risks in female athletes. In terms of treatment, there aren't really any differences in how we treat male versus female ACL ruptures. So there's operative or non-op. That's kind of the option for any injury ever. If you're a young active athlete, you definitely are going to go the operative route, which again is ACL reconstruction. Once you go operative, there's different choices of graft. You can have what's called a bone-to-bone graft that's using largely your patellar tendon. You can have a quad graft. You can have a hamstring graft. You can have an allograft, an autograft. There's lots of different options. And so far, the research hasn't shown any differences in the efficacy of these different types of grafts in ACL rupture generally. One thing that is coming up in the literature, though, is this last bullet point, ACL-LET reconstruction. So ACL, we know what that is, but LET stands for, oh man, I didn't write it down, lateral extra-articular tenodesis. And so what this is providing more support on the lateral side of the knee to really prevent the rotational instability that you see with an ACL injury and that they feel like our female athletes are at a greater risk for. So again, with that greater Q angle, greater valgus stress, they have this greater rotational instability, and that by using this extra part of the procedure, the LET, that is providing more stability on the lateral side to improve outcomes for our female athletes. So this is, this has been a much more popular technique outside the US. It's gaining favor in the US, but particularly in younger female athletes. Case reports that I've seen have again focused on using this form of reconstruction, specifically in female athletes, to increase their stability. So again, they have this increased risk of ACL re-rupture after an initial rupture, and adding on the LET part either during the initial reconstruction or later on. So again, I saw case studies that were looking at it. They'd had an ACL surgery a few years ago, but they still felt like their knee wasn't quite stable. So they had just an isolated LET procedure and felt that helped them stabilize a lot. So this is like a newer part of the operative spectrum that, may be, again, should we be treating these injuries differently because there is a higher risk of injury and re-rupture in our female athletes? If we think that yes, treating differently is appropriate, then so far this ACL LET reconstruction seems to be popular in terms of how we address female athletes with ACL injuries and continued instability. And then one other thing that showed up again in the research and in the article that you may have read before is that, again, despite males and females, we both have ACL ruptures, and yet there seems to be an increased amount of male athletes or males with ACL ruptures who end up getting an operation, who end up getting ACL reconstruction compared to female athletes. And we don't know why that is exactly. Like, why are our male athletes like getting the surgery and getting the surgical option more than our female athletes? Not sure. And there's also shown that, again, females who end up getting the surgery a lot of times don't return to sport at the same level or at the same percentage that our male athletes do. So why is that? So it seems like in the treatment realm, there's opportunities for improvement. We have female athletes with a high rate of rupture, high rate of re-rupture, and yet they're not getting surgery at the same rate as males, and they're not returning to sport at the same rate. So clearly there's opportunities for improvement in how we can prevent ACL injury and treat ACL injuries for our female athletes. And not anyone who's a weekend warrior too counts as an athlete. Doesn't have to be a professional athlete. I just want to clarify that. So yes, next slide. Now, like I said, there's a lot of opportunities in this space of sex and gender differences for sports injuries, for ACL injuries, but for a lot of different topics. Again, we talked about for transgender athletes, we talked about the hormonal effects, we talked about the treatment differences and treatment outcomes. But now I would love to hear from you guys. What questions do you have? What thoughts do you have on this topic? And Dr. Alvarez, of course, feel free to jump in with anything.
Okay, I'm gonna let you guys, come up with any questions, any comments, and then I'll jump in and give you my take.
I mean, I feel like it seems like there's still a lot of research to do in the field. So I'm really excited to see what like the next couple of years, like what direction this field is headed to with, I feel like there's gonna be a lot of insight that we gain. So I think I'm just like in general excited. Like I feel like I wasn't really aware of the topic in general until you brought it up and did this presentation. So I feel like with that, there's like, that just goes to show how much like there is for all of us to learn. So I'm excited.
Okay, so can you guys hear me? First of all, I'm really impressed, and I really like what you guys are doing. I was very busy this weekend. I've had a bunch of games that I had to cover. I was in training this morning with the athletes, and but I said, you know what, I'll make it. I have two things that I want to discuss with you guys. First thing, I'm trying to get all the information I can. You know, I'm currently in my fellowship, so all the information I can get makes me get better every day. And this is a very interesting topic. And usually when we get this kind of patients, we get them once the injury has happened, once the ACL is already torn. But this is really important because it gives us an idea and do something that is sometimes more important in medicine, which is to prevent. So if you know the risk factors and you know what might increase the risk of an injury, then you can find ways to prevent it. So this is why this is really, really important. And on the case of ACL, we're seeing a lot of patients, and it's interesting. I had a notion before coming here, you know, ACL, you need to get surgery right away. But 65% of people that get an ACL, depending on their activity, like you said, if you're an athlete, very active, young, you might want to go for surgery. But if you're probably older, not as active, like I said, 65% will do just fine with a surgery. Send them to physical therapy, make their hamstrings very strong, and they will take over the function of the ACL, and they will be just fine. They will live their lives without any problems. So it's an option for them to go the conservative route, depending on their level of activity. So factors that increase the risk, like you said, there are many, and there are very interesting questions that can come out of this topic. And that is something that I wanted to bring out for you guys. I was discussing it with Samantha. One of my tasks during my fellowship is to do research. And to be honest, I've been hammering my head trying to come up with a question, an interesting question, something that, you know, we would like to answer. And you guys are welcome to help me. I think I spoke about this with Samantha. You guys, like I said, I'm impressed with what you guys are doing, and I could really use the help. You know, we're all very busy, and you probably do and know more about research than I do. So if you have any questions regarding what I do or anything, just go for it.
Yeah, we'd love to help you out on that. We can talk more a little bit later and maybe let me know how many people exactly you want, and we can gauge some interest from our team on who would be interested in doing a project like that with you.
Okay, perfect.
Does anybody have questions for Dr. Alvarez or Alex, or should we keep going? So there's some more presentation, right? Yeah,
Are you all students?
we are. Yeah.
Okay. Anybody interested in sports? I can see Alexandra, she already mentioned. Yes. So you want to go into orthopedics, or you want to go, you know, the non-surgical route?
At the moment, I'm shooting for orthopedics, but I definitely enjoy sports medicine overall.
No, I mean, at some point you might, when you finish your residency, you might go into a sports medicine fellowship. Most of them do it. So it's great.
All right, let me just go through the last couple of things on my presentation. And then of course, again, like, please feel free to ask me questions or ask more questions for Dr. Alvarez. So again, I thought that this topic was interesting in general, you know, from a research perspective, which is what the Caribbean Research Group is kind of focused on. But we're all students. And so looking at, you know, why is this topic important to know for things like step 1 and step 2? So ACL injury does come up in our examinations, and so and other ligamentous injuries. So like in the knee, we specifically see things like ACL, PCL, MCL, and LCL injuries, meniscus injuries. And so when you see a step 1 or step 2 question, they will have these questions will be presenting you a specific type of patient. So if it's telling you it's like this really active, you know, young woman it's probably trying to get you to think more of, what are these injuries that are more common in our young female athletes, and ACL is definitely one of them. So they'll give you a very specific type of patient with some specific symptoms, like again, that pain, that popping, that swelling, the knee catching or giving out, things like that. Or also the mechanism of the injury. So like again, maybe it'll tell you it's a soccer player, or that they landed from a jump or something like that. So these are things to look out for in that question. Again, there's a reason they're telling you the patient specific age or the patient specific sport. Like there's something that they're trying to get at. And then, what they're going to ask you, they may ask you the nice, simple level 1 question of just, what is the injury? Is it an ACL? Is it a PCL? That kind of thing. They could ask you to identify the next best step in management or treatment. How do we diagnose it? Is it like, need to do the Lachman test of the anterior drawer, need to do the MRI, or we need to tell them to do PT versus operative, like those kinds of things. And lastly, a type of question could also ask you, what other additional findings might you see in this sort of patient? So say someone, they give this whole description of someone who has like an ACL injury, but they've only told you that they had, pain and popping, and so they're asking you for an additional relevant finding. An additional relevant finding could again be that anterior gliding of the tibia relative to the femur, or something like that. So again, another key part to know related to ACL injuries, that again, there's a lot of risk factor questions on step 2 in particular. The ACL injury and repair is linked to an increased risk and earlier onset of osteoarthritis. So I've seen that question come up a bunch of times in practice questions. So that's just there's a lot of, in general, step 2 wants you to know what are risk factors for X, Y, and Z disease. For osteoarthritis, if someone in the question description had an ACL injury, that's definitely going to impact their risk of OA. And then again, when we're talking about, step 1 and step 2, sorry, next slide, they may also just give you images of things and expect you to know what you're looking at. So MRIs, I think, are a little bit more difficult to analyze in general. So I just wanted to make sure to post a couple pictures of what you would expect to see if a question's asking you about an ACL injury. So on the left is a nice MRI of what a normal ACL looks like. The green arrow is pointing to it. And so again, you can know it's the ACL because it's going more from the posterior part of the femur and moving anteriorly to the more anterior tibia insertion. And then on the right, you see an ACL tear because you just see a bunch of mush, to be honest, a bunch of fibrils all over the place. There's not any linear connection anymore because it's ruptured. And the next slide is again just another similar image, but different, different weightings. So the first image or this last image here, for example, is like T1 MRI versus T2 MRI is in the middle. So again, you can still see similar things. You see this nice linear ACL on the left versus just fibrils everywhere in the middle. And then on C, you can see, you can still kind of see the ACL is there, but there's an obvious detachment from the tibia at the anterior side. So make sure that when you're studying, know your risk factors, know your imaging, know all the different physical exam findings you may find for something like that. And lastly, on the last slide, I just wanted to talk about when you get answer choices on step 1 and step 2, being able to understand what exactly they're getting at will help you rule out a lot of things. So this was like a whole bunch of different answer choices that I took from a step 2 question on UWorld. And so if the answer choice is telling you, anterior translation of the tibia on the femur, what sort of injury are they talking about? We can be interactive again. That's the injury we've been talking about this whole time. That's ACL. If you click twice, I think. Yeah. And then, so something like this description, apprehension with lateral translation of the patella. If you click, this is patellar instability. So again, your patella should be in this trochlear groove. If it's moved to the lateral side, there's some sort of instability there. If you have erythema and effusion of the medial joint line, what's at the medial part of the knee? That could be like your MCL or a meniscus, but also erythema and effusion. You can think of gout or something like septic arthritis. They'll give you a lot worse clinical picture if it's septic arthritis. Inability to extend the knee. What extends our knees? Our quad muscle. So if you can't extend it, you probably have an issue with your patellar tendon or your quadriceps tendon. If you have pain with isometric contraction of the quadriceps, then you're getting into patellofemoral syndrome, which also has an increased risk in female athletes compared to male athletes, but that's a topic for another time. And then finally, if you have tenderness of the tibial tubercle, that is kind of pathognomonic for Osgood-Schlatter disease. So when you're going through questions, don't just go through questions, get the right answer, move on, but like make sure you understand what all the rest of the answer choices are saying. Because if you can look through this slide and you understand what all of these are saying, then you can easily rule out an answer that has nothing to do with an ACL injury, for example. So those are just some tips and tricks learned from having recently taken step 2 and, again, related to this topic of ACL injury. So I just wanted to share that as well. The next 2 slides are just my references. Again, this was like a lit review, so there's a lot of them. But, thank you again for listening. And again, at this time, any other questions for me or for Dr. Alvarez, please feel free to speak up.
This is not pertaining to the article itself, but just like a question to think about. Do you think like the gender difference of, or the sex difference of the perception of pain could affect how these injuries are being treated for and what the outcomes are?
So I can say that, for example, with concussion, there's definitely been some research showing that there's an increase in, like, there's a significant difference in reporting the injury. Female athletes tend to report concussion much more often than their male counterparts. And also that the description of symptoms, again, like you're saying, like pain or neurocognitive symptoms that they're expressing, that female athletes are expressing in concussion is very different from what a male athlete. So it's the same underlying disease process, but different, subjective experiences. And do I think that's possible with ACL injury or any of these injuries? Absolutely. Whether someone is more willing to say that they have an injury can be influenced by many factors. And a lot of it is, again, going to be more societal, so more of this gender-based differences, I think. And then in terms of, perception of pain, I don't know if I would classify that as gender difference or sex difference or just, a combination of the two. But I think that there's definitely can be differences in how people of different backgrounds, sex or gender wise, that they express this injury. And then, like you're mentioning, may have different outcomes as well.
Thank you.
All right, any other questions, guys, or concerns about anything? If you think of something later, you can always message, email us or message Alex. Alex, sorry, were you going to say something?
Yeah, I was just going to ask Dr. Alvarez a question. If he could talk a little bit more about his path to sports medicine and, the options for getting involved in sports medicine, in medicine overall, because there's a lot of different paths. I said I was interested in orthopedic surgery, but he started with family med. So if he could chat a little bit about that for the group, that would be much appreciated.
Thank you for the question. I've always been very, very active. I think I started playing soccer when I was like, I don't know, 9, 10. I lived in South Africa for 2 years. I went to school over there. Soccer was big in South Africa. So I got involved a little bit over there. When I came back to Cuba, I played in my neighborhood, bare feet on the street. And then I went to play in medical university. We won a bunch of tournaments. So I've been always involved in soccer, mainly. It's my favorite sport. Also a little bit of weightlifting and something else. And, you know, my medical career took off, always wanted medicine. Um, Went into family medicine. I tried to avoid the hospital. I like, having the patients at the office, talking to them, getting the history. And then when I started my second year in residency, I actually found out that sports medicine was a fellowship that family medicine doctors could do. And that's when I got the idea. And I said, you know what, I can mix both of my passions, medicine and sports. So, like I said, I made the decision to apply my second year of at the end of second year, and I got in, and like I said, I couldn't be happier. I mean, can you like being a physician on the sideline? I was just on a big game on Friday. It was an amazing experience. Uh, and like I said, I love it. I love it, and it's great. I was there with an orthopedic surgeon. He also covers the game, so you feel a little bit of that you're protected, and you get a lot of experience as well. At some point, I'm going to be by myself as I move along, but it's great. It's a great experience. I love it. I love it. I can get to be a doctor and manage the diabetes, the hypertension, and I can also manage their MSK problems as well. And so it's good.
Dr. Alvarez, can you also talk like a little bit about lifestyle, like when you are a sports medicine physician, like what does it look like?
That was one of the things that also brought me to make this decision. As you all know, and you probably will know, those that make the decision to go into internal medicine, family medicine, at some point you're going to be dealing with the stress of seeing a high amount of patients every day. Uh, they come in with, lots of complaints because, they're sick, and there's a lot of stress. You have to follow a lot of problems. You have to follow their screening. You have to follow all their conditions. Some people will come in with lists of problems, hypertension, diabetes, colon cancer screening and all that stuff. When you focus on sports and you become a specialist, that it's not that you put it to the side, but usually they have a primary care physician for that. And then you become more of like the specialist and you deal with the other problems that they cannot handle or they need your assistance with. So the the burden just goes down completely. You don't have to follow a lot of labs. You basically just follow any imaging if you send it, like an X-ray, an MRI, and then your treatment options are what you have. You either send them for surgery or physical therapy, or manage them conservatively with pain medication and stuff. So it becomes easier. It becomes easier on yourself, on your life. So what can I say? It's benefits all around. So
Pretty convincing argument for sure. Yeah, it's good to hear from physicians in the field about, the lifestyle, because that's something a lot of us consider when choosing what to go into. So appreciate your intake on that.
yeah, I mean, I don't want to bring it up a lot because I have my colleagues that just graduated with me, and they're going through the pain, and I'm over here, just dealing with MSK, which I love, and
Yeah, sounds great.
so like I said, I'm impressed. I'm impressed. Thank you guys for having me, and
Thank you so much for being here. We really appreciate it. I'll touch base with you about that project a little bit later. And any final questions, guys, for Dr. Alvarez or Alex? If not, Dr. Alvarez, thank you so much. Have a great rest of your day. And for everyone else, please stay on so we can finish our CRG business. Bye, Dr. Alvarez.
bye guys. Thank you.
Thank you. Okay. Sorry, guys, I can't see participants right now, but I think it's just members, right? If someone can confirm that for me.
Yeah, it looks like it's just us.
Okay, perfect. Do you think I should let me stop the recording 1 second and then I'll restart it.